You may have heard someone talking about low-dose naltrexone, or maybe if you have a chronic health condition, you've seen it mentioned in some of the message boards. Low-dose naltrexone has some really promising research around it. My name is Nari Kaur Clemons. I'm a certified pelvic rehab specialist. I'm not a doctor, and I'm definitely not your physician. So I'm going to do some information here and hopefully give you some talking points to discuss with your doctor, give you some good sources to learn about this, and let you know about a couple studies and what the trends of the studies are showing us so that you can have an informed decision with your care provider. So let's talk a little bit about where this drug even came from. Naltrexone was a drug that was originally created to help people get off opioid dependence. So when we look at some of the drugs that are used for that, there's Suboxone, Methadone, Naltrexone. They're all in the same family of drugs. There was research done on low-dose naltrexone a while ago. I think it was in the 60s, as a drug that seemed to show promise with getting people off of narcotics. But what they found in the studies is it wasn't the best choice because of the amount it interfered with sleep. I find when I take this, and many patients who take this find, it puts them to sleep in the short run because what it does is it blocks the opioid receptors in your brain. So your brain is like, I don't feel endorphins. And that's how it originally worked to help people not be on drugs because they didn't get the high that they would normally get from the drugs. And so it made them less motivating to take. So that happens, but then you have less endorphins in your brain for a number of hours. And then our brain always has, our whole body has homeostasis mechanisms where when it sees something is low, it fires up pathways to help raise what it senses to be low. Our body's like the most sophisticated machine there ever was. It's quite miraculous. So then what happens is your brain, your body notices, oh, there's not enough endorphins, and so it starts to produce more. So then when the drug starts to wear off in 4 to 5 hours, you kind of have a flood of endorphins in your brain, and then you're very energized. So what can happen is people can take it at night, they'll fall asleep really well, but then sometimes they might be awake 5 hours later. Now, this is more of a problem at the higher doses. So in the research studies, people were taking doses, or even when this is used for drug rehab, the pills that are typically made by pharma are about 50 milligrams, I think it is, and people will take up to 200 a day. But what they found in the studies is wasn't so great because it kind of had people have a low and then a high in terms of their energy levels or sleep or capacity to rest. But the people who had Crohn's disease and ulcerative colitis, which are both autoimmune inflammatory bowel diseases, went into remission during the studies. Then time went on and some doctors, scientists, researchers started saying, wait a minute, why did that happen? And so then experiments, testing, clinical data, grassroots movements happened where people were seeing how low could you get in the dosing to help autoimmunity. So instead of like 200 milligrams a day, most people who take low-dose naltrexone settle in around 4.5 milligrams a day. So it's a small percentage, like maybe 1/50th the amount that somebody was taking in the studies, because people start at 1.5 often and they go up to about 4.5. Now some doctors have people taking more, but 4.5 seems to be like the most common dose that people take. What has been shown is first there were research studies done on MS, and it did show that it was helpful in stopping the disease process and in some cases putting people into remission, in some cases people actually getting healthier. Then it started being tested for more and more autoimmune diseases, and there was a positive outcome in many of them. Now, if you have a specific autoimmune disease, the best place to look for research is to get on PubMed. That's the National Institute of Health database. And then you can put in low-dose naltrexone and the autoimmune disease you have, and you can see if there are studies that support your particular autoimmune disease. But here's what's amazing. Now more research has been done on chronic pain, fibromyalgia, and inflammatory pain. And There are studies that look at one thing, and then there are studies called systematic reviews, or sometimes they're called Cochrane reviews. And what those are is they take all the studies about something, a researcher will, and then they will say, I'm going to look through these and find the ones that were the highest quality, that were really done well. Then they summarize the study findings of all the very well done studies and see, do we have a common consensus? So in the systematic review for chronic pain, for fibromyalgia, low-dose naltrexone has been shown helpful, and also for anti-inflammatory properties. So for many autoimmune diseases, this can be helpful, or for chronic pain. I also find that my patients who have endometriosis definitely report lower pain outcomes when they're on low-dose naltrexone. And I have seen dozens of patients, now this is anecdotal, I'm not a researcher, with interstitial cystitis who finally found some relief when taking this product. Or maybe I had some patients who had chronic pelvic pain where intervention alone wasn't helping, whether that was diet, lidocaine, therapy, whatever the combination of conservative therapies were. And I've seen a number of patients where when they did add an LDN, that was the thing that allowed the more conservative therapies to work. So it's certainly not a fix-all, meaning if somebody's going to be smoking and not managing stress and eating a terrible diet and not sleeping, I don't think you can throw in a little LDN and everything's great. It probably doesn't work that way. But can it be a helpful additive to your care plan? This is definitely worth discussing with your doctor. There's a really good website called the LDN Research Trust, and they publish the latest data on LDN. One of the tricky things about LDN is it often has to be compounded at the doses that it's used. So what does that mean? Well, if the pills that are available at the traditional pharmacy are 50 milligrams and you're trying to get 1.5, you can't just cut that pill in half because that's a too small dose. So special pharmacists who make things that aren't available typically over the counter or even over the pharmacy counter with prescription, they formulate it in smaller doses that are standardized because you don't want to take 1.5 one day and 3 the next day. You can get headaches and some things when you're first adjusting to that medication. And I'll make a different video on like what are some of the tips and tricks my patients have found to get to the right dose for themselves. And that compounding process though that these pharmacists do, that can be expensive. So often a compounded pill, those can run almost $1 each. So sometimes for some patients, even more than that. I've seen sometimes where a 30-day supply can be $100, and insurance is generally not covering that. Now, as this drug has become more common, for example, we have one pharmacy here in Portland where they purchased a machine that can actually compound it and make it into tablets. And since you don't have to have one pharmacist doing that, that makes it way cheaper. So the 4.5 tablets, for example, there are like $70 for a 100-day supply. So like 70 cents a day. Also some of the online pharmacies like Hers, Hims, some of the longevity pharmacies that are coming out, they have it for way more affordable pricing because they're doing such a large volume of it. But I strongly advise anybody that you don't really want to have one doctor who's regulating your medications and then be getting a different thing online, whether that's a GLP med or low-dose naltrexone, if your primary physician who's monitoring your meds isn't aware. Like you want to make sure you're communicating well, and then maybe if that's a more affordable sourcing that your doctor feels is reputable, that's fine. But you don't just want to be like having 4 different doctors that are prescribing things and people aren't communicating. That's never a good idea for your health. One of the other things you have to keep in mind, if you're going to have a surgery, it's recommended that people get off of it 3 or 4 days before, because otherwise the pain relief methods that your physician may give you, like a couple days of narcotics or other things like that, that might not work. And I don't even know how that would affect anesthesia. So you certainly want to be above board with that with your doctor and make a plan with your physician, how many days you need to get off of it before surgery and how many days after surgery you could resume it. For more tips and tricks about little things that might help your pelvic health or your body as a whole, I'll see you in the next video.